Assalamu alaikum, everyone. Allahu Mubarak. Hope everyone's doing well. And yeah, the first day of fast is going well. I'll try to keep it short and quick and keep it to the high key points. If you have any questions, feel free to ask or put them down in the chat box. So yeah, yesterday we covered the a couple topics that are mentioned here. Today we're gonna start off with psych emergencies, and this is quite high yield. Uh, So yeah, the first condition I want to talk about is serotonin syndrome. It's a potentially life-threatening condition, and this is mainly due to the excess serotonin in your central nervous system, and it's usually due to a combination of drugs. So your SSRI, SNRI, MAOIs, TCAs, or other drugs like MDMA, or linezolid or dextromethorphan. So combining these drugs is most likely the cause of this. Okay, and classically it presents with a triad known as the three A's. Okay, so the three A's triad is altered mental status. So you'll be agitated and confused, autonomic hyperactivity, which is fever, diaphoresis. You'll have tachycardia as well, and neuromuscular hyperactivity. Okay, so these are the three A's: altered mental status, autonomic hyperactivity, and neuromuscular hyperactivity as well. So you have a tremor, you have clonus as well. Okay. So you have to know this is a big difference that you have clonus here and hyperactivity here. Okay. Uh, and I'll tell you why this is important. Because this is what differentiates it from, and this is what helps you. This is one of the things that helps you when you see a scenario versus malignant syndrome, which we're going to discuss now as well. Okay. So neuroleptic malignant syndrome is another high yield emergency, and it's caused by taking antipsychotics. So medications are basically uh, dopamine or D2 receptor blockades medication. Okay, that's what causes it. And NMS usually develops over days to weeks after starting or increasing the medication dose of medication, while serotonin is much more quicker. Okay. And patients present with mental status changes. So they'll have like encephalopathy or confusion. They'll have hyperthermia, so they'll be, feverish, and they have something called lead pipe muscle rigidity. Okay, so this is something you should know, and autonomic instability. Okay, so they're not going to have hyperreflexia. They're going to be rigid. Okay, they're not going to have clonus. They're going to be rigid, and they're going to have hyporeflexia. Okay, in contrast with serotonin, which is clonus and hyperreflexia. Okay, and it's very important for you to know these differentiations because they give you it's a very common question to come in the exam. Okay, so typical USMLE STEM will be like, a patient started on monoamino oxidase inhibitors, took another medication, maybe a cough medication or whatever, because he was like, sick, and he took some cough medication, and now he has like a fever and he's agitated. And, oh, this might sound like neuroleptic malignant syndrome, but he's actually not on any of the dopamine medications. And he has ankle clonus. So think serotonin syndrome. And the key feature that's going to help you differentiate is hyperreflexia and clonus, which are often present in serotonin syndrome. Okay. Management is usually stop the medication he's taking and give him cyproheptadine, which is a receptor antagonist for the 5-HT2 receptors. Okay. 5-HT2 receptors, actually. And this is the antidote. Okay. Uh, in regards to neuroleptic malignant syndrome, a vignette might just, adult who's on like haloperidol, and he develops like high fever, confusion. See similar stuff, right? He's on some medication and he develops like uh, sympathetic hyperactivity, right? So there's all sympathetic hyperactivity, and then he has severe muscle rigidity. Okay. You can also see very high creatinine kinase. Again, this is because of hyperreflexia, okay? And muscle rigidity, okay? Because he has severe muscle rigidity leading to this. Think of NMS, okay? So Treatment is you first of all you stopped the antipsychotics, okay, he's taking and whatever medication he's taking, and you provide, IV fluids. Pharmacologically, you're going to give him dantrolene, okay? It's a skeletal muscle relaxant, and it treats malignant hyperthermia, if anyone knows that. And you can also give him bromocriptine or amantadine, okay? Again, those are dopamine agonists, which are going to help, reverse the dopamine block. So, a mnemonic that's good for neuroleptic malignant syndrome would be fever. So fever, F stands for fever, E stands for encephalopathy, V stands for vital instability, E stands for, elevated enzymes, and R is for rigidity. Okay. Uh, uh, yeah, any question that really usually gives you neuroleptic malignant syndrome, the correct answer is usually administered or dantrolene or bromocriptine. That's usually the answer. Okay. Another one I'd like to discuss right now would be like I think we will do it afterwards, but I'll just mention it right now would be uh so just one thing is like a lot of stuff I'll say is not on the slides. I'm just going over stuff that's in my head. So yeah, we'll mention like delirium tremens, okay? Although we're going to talk about alcohol and other disorders, real quick, it is also a psych emergency, and it's usually from severe forms of alcohol withdrawal, and it's like typically occurs 48 to 72 hours after the last drink. And the person usually has heavy, prolonged alcohol use, in the history. And he develops like delirium, so, acute confusion and, his agitation, fever, all sorts of things, hypertension. You also, classically has like visual hallucinations, like they'll tell you he's seeing like bugs or whatever crawl on the wall. And they also have like severe tremors, they're sweating a lot. um, and it's very life-threatening, okay? And interestingly, or like not interestingly, I guess it's statistically about it has a 20% mortality if left untreated. So recognizing is quite important. So the classic scenario is going to be a patient got hospitalized, and 2, 3 days later he starts, just normal in the hospital for, let's say, I don't know, pneumonia or whatever. And then 2, 3 days later he starts having this, he starts uh becoming confused, hypertensive, tachycardic, diaphoretic, hallucinations are happening. And you're like, oh, what's going on? This is just a normal person in the hospital and has been there for 2 days. Well, what happened is he couldn't have a drink for the last 2 days. And now he's in this emergency where there's a 20% chance he dies. So the treatment is prompt administration of benzos. So you give him like IV diazepam or like lorazepam, and that should calm his CNS down, and that should help him, okay, and prevent progression. Uh, Also, you give something else to note for this would be thiamine, because they usually ask you what else do you give him, because you give thiamine because to prevent Wernicke's encephalopathy. That's something I guess you guys should know by now. Uh, and yeah, those are two things you'll give, okay? This is the test for clonus and serotonin syndrome. I think you guys know clonus. You guys took it in, should be taking it in your pro, so you guys should know what it is. Uh, Next thing we're going to talk about is these two things. So acute dystonia is also a side effect of antipsychotics. So basically, acute dystonia is involuntarily painful muscle contractions, and that can occur within like hours to days of starting a typical antipsychotic or increasing the dose. Okay. A patient might present with like, something called torticollis, which is like neck spasms causing the head to tilt, or like you have something called, they might have their eyes going upwards. That's called like oculogyric crisis, okay? Or their jaw spasms out, okay, and they can't swallow. And it's very frightening for a patient because, uh, obviously these things are just something random. They're just normal, and then next thing they know, they're spasming out, right? Uh, so the treatment would be directly giving them anticholinergic medications like benztropine, or like diphenhydramine. Okay. These are anticholinergic and they will relieve the dystonic muscle contraction. So, question would be like, young man who started haloperidol yesterday, and his neck is now twisted to the side, and he's in like severe distress. Okay. What's the answer? Benztropine, IM. Okay. Uh, this is not as life-threatening as the previous two mentioned, but it is still quite distressing for the patient. Uh, the other one is hypertensive crisis, which is caused by uh, you know, tyramine-rich foods. Okay, so it's usually in a patient who's on MAOIs, okay, antidepressants, and they consume a lot of tyramine. So tyramine is found in like aged cheese, cured meats, wine, all these things. Uh, and it's normally metabolized in the gut, but when someone starts taking MAOA inhibitors, so, you know, any of the ones they mentioned, like, phenelazine or whatever, uh, it prevents the breakdown of tyramine, and ingesting high amounts of tyramine can lead to hypertensive crisis. Okay, so sudden explosive headache, high BP, can lead to an intracerebral hemorrhage as well, or stroke-like symptoms. Okay. So if you see a patient that's on MLIs and he goes to, classic is like, oh, he went to like a party and then he developed like severe headache and his blood pressure is like 200 over like 120. And yeah, there's a hypertensive crisis and you treat with, fast acting alpha 1 blockers. So something like phentolamine. And yeah, this is why it's very important, anyone that's on MAOIs, to have like dietary restrictions, okay? The next one is lithium toxicity. Uh, and this can also be considered a psychiatric emergency. So lithium is used for bipolar disorders and it has a very narrow therapeutic window. So toxicity can occur due to like overdose or, situations in which the that decreased lithium secretion. So if the person's like dehydrated or there's like, drug interactions such as using thiazides or something. Okay. Uh, so the signs of lithium toxicity are basically you have tremors, ataxia, confusion. They can even get seizures. Okay. And seizures are an interesting one because you're not going to see that in a lot of other ones. And this is something to note here that you're not going to see seizures in other toxicities. So if you're seeing seizures, it's most likely going to be lithium. It can lead to coma or death as well. So it's pretty severe. Uh, Management would be directly to stop lithium and hydrate the person. And in serious toxicity, hemodialysis is indicated. Okay. Uh, in a classic in exam vignette is going to be like, he's on lithium. After he started taking, they say, oh, he's hypertensive, so they gave him like, I don't know, or he's in pain, whatever. Either they gave him a thiazide diuretic for like hypertension, or they gave him like NSAIDs for something, and now he's like, just has tremors and he had a seizure, or whatever. What is going on? This is what's going on. Okay. And it's also important to remember that there are side effects of using lithium, the chronic side effects. So they can have like nephrogenic diabetes insipidus. Uh, it also causes teratogenic effects like Epstein's anomaly, and like hypothyroidism is something as well that's common. Okay. Uh, what's it called? But for an acute context, just know like, specifically like tremor and confusion, and seizures for lithium toxicity. In regards to TCA overdose, you're going to see a person that might have like respiratory depression. You have the general like uh, what's it called? Symptoms will be like respiratory depression, hyperpyrexia, as mentioned here, prolonged QT, tricyclics. You have convulsions. coma, cardiotoxicity, right? Uh, and the main thing is uh you do treat with is supportive management mainly. Okay, try doing ECG to see if there's any problems and any cardiac toxicity that's happened. If not, you also give sodium bicarbonate for these people as well. Okay. Uh, sorry, not sodium bicarbonate. This is sodium HCO3. Okay. That's what you give them. Okay. Uh, so in summary, I guess know about serotonin syndrome and how you treat it. Cyproheptadine. There's clonus. NMS would be dantrolene and bromocriptine. Rigidity. Delirium tremens. Alcohol withdrawal. Benzos. You have tyramine, which is uh, you know taking MLIs and given some other started eating a lot of tyramine stuff treated with phenethylamine. You have acute dystonia, and that's benztropine treatment, and then you have lithium toxicity, and we just mentioned tricyclic. Okay. We'll move on to substance abuse and discuss. Yeah. So this is something that's sometimes asked in step one about like, what stage is he in of, the model of change. That's why I added it. So yeah, this is something you guys should know, model of change. Like if he's in pre-contemplation, contemplation, is he in the preparation of change, or is he like uh is he in maintenance or relapse or action, right? So they'll give you a scenario in which, like, let's say a person smokes a lot and, he had a discussion with someone, and now is he in which stage of change is he in? Something like that. Okay. It's pretty straightforward, but just wanted to give an example of how it's really exam. In regards to substance abuse, talk about the biggest one would be alcohol. Okay. Uh, so in general, uh, is depressants like, a general rule would be depressants like alcohol, benzos, barbiturates, and opioids. They tend to cause like sedation, and you should always think they also cause respiratory depression and impaired like coordination, right? So like confusion type, right? And withdrawal would lead to life-threatening illness. Okay. So they're life-threatening depressants usually if you withdraw from them, right? So seizures and autonomic hyperactivity, and you can really, really, most likely die from all these, right? So alcohol withdrawal can lead to death. Others can also lead to death, right? As opposed to stimulants, okay, they cause increased arousal, they cause tachycardia, hypertension. So your stimulants are going to be amphetamines, cocaine, or whatever. They can also lead to psychosis, and withdrawing from them does not let you, withdrawing from them is not going to cause like life-threatening consequences, but it can cause like a crash. Okay, so they cause like depression and fatigue and like increased appetite. Okay. In regards to hallucinogens, which we're going to discuss, they basically cause like, they change your perception of reality, but they're not fatal, okay? Their intoxication is not fatal, uh, and withdrawing from them is also just mild. It's not that much of an issue, okay? That is a general rule for you guys to know. Uh, so now we're going to start off with alcohol. So alcohol intoxication is extremely common. Uh, Acute alcohol use is like, it's a CNS depressant. Intoxication is going to cause slurred speech, ataxic gait, impaired judgment, disinhibition, and can also cause nystagmus sometimes. Uh, in an exam question, moderate alcohol intoxication might present as a patient who's at a party, and he's like unsteady with slowed reaction time and talkative or like aggressive behavior. Okay. And severe intoxication is going to lead to coma and going to lead to, as I mentioned, respiratory depression, and can be fatal if the blood alcohol level is too high. Uh, so one lab clue for like chronic alcohol use is going to be elevated GGT, and an AST AL2 ratio of 2 to 1. Okay. So AST is usually higher in alcoholic liver disease. That's basically what it means. And for acute alcohol intoxication, management is mainly like supportive, and they allow time for like metabolism of the alcohol, and they just monitor him like in general, right? In like the emergency setting, IV thiamine is usually given, okay, to avoid Wernicke's encephalopathy, which is usually the concern. And in alcohol withdrawal, it's like a big spectrum. So you have like the 6 to 12 hours. After the last drink, a patient usually develops like tremors. It's called the shakes. And then insomnia, anxiety, sweating, and palpitations. So 12 to 48 hours they can get like a seizure. It's called alcohol withdrawal seizures. Uh, and they're typically like tonic-clonic seizures. Uh, and then like alcoholic hallucinosis is uh usually visual hallucinations, like they see insects and like, that's what they tell you. Oh, you're seeing like bugs crawl on the wall or something like that, okay? And then delirium tremens, as we mentioned, is like the most severe one that's like post 48 hours. And it's like, fever, autonomic instability, all that, okay? So benzos are the treatment. Sorry, excuse me. So diazepam or chlordiazepoxide, something like that, lorazepam. If so, you give lorazepam if he has like liver disease. I don't know if this is like important for you guys, but yeah, lorazepam if he's like severe liver disease, you give him lorazepam. Okay. On So on exam, if you see someone who's in the hospital and tremors and hypertension 1 or 2 days after admission, this is alcohol withdrawal, and you give them IV benzos. Okay. Uh, the next we're going to talk about is opioids. Opioids are this section is heroin, morphine, oxycodone, hydrocodone, fentanyl, any of these. Okay, these are all opioids. Okay, and it's very characteristic signs. Okay, so you have meiosis, so pinpoint pupils. Okay, respiratory depression and CNS depression. Pretty straightforward. Okay, pinpoint pupils, respiratory, and CNS depression are the main points you need to know. They also have constipation, so that's like on the side, something for note as well. They may have like slurred speech, impaired attention, they become unresponsive when they overdose, and really shallow breathing and respiratory rate. And this is what causes the death, right? The respiratory arrest. Other things you might see is needle track marks if they're like drug abuse users, okay? And uh they'll have like skin itching and flushed skin as well. Okay, that might also be like, oh, they scratch their skin a lot, and classic stuff you've seen in like movies about like druggies or whatever, right? Uh, there's usually going to be like a scenario of like a young adult. He was found down with like constricted pupils. He's not breathing that well, and revive it with naloxone. Okay, so that's acute overdose, and basically the antidote is naloxone, which is like a short-acting opioid antagonist, which rapidly basically reverses the effects of opioid. Um, so because naloxone itself can like precipitate withdrawal in an opioid dependent person. Okay. So in an exam question, they could also tell you like they administered naloxone and the patient goes from like comatose to awake and then with agitated symptoms of withdrawal. So I hope that makes sense. Like it itself is going to induce the withdrawal symptoms. So if a person is like, just comatose, he's going to go into the other withdrawal symptoms. Okay. Uh, just know that opioid withdrawal uh is not as like life-threatening as alcohol withdrawal, uh but it is very uncomfortable. Okay, classic description is like flu-like symptoms. Patient is like yawning. He's gonna have lacrimation, rhinorrhea, sweating, piloerection, like goosebumps, and they feel very cold. That's why they're like shiver and stuff, like like cold turkey, like, okay. And their pupils are going to be opposite. They're going to be dilated, okay, midrasis, okay. They'll have like joint pains and cramps, and as I mentioned, like So they're going to have diarrhea, by the way. They're not going to have constipation. So opioid use is leading to constipation, which is basically opposite of everything they had in opioid use. Okay. So like basically, they can say like everything that was going down is going up basically in withdrawal. Okay. Uh, and he's going to be scratching and he's going to have intense craving for like opioids. So they'll say like, oh, 24-year-old who's like, a heroin user, and now he came to the hospital and he's like saying he has like a lot of pain or something, and like he's he looks like sick, he has like a runny nose, yawning and all that other stuff. And you can tell, okay, this guy's like, he's saying he has pain, so he's obviously asking for some sort of medication. He wants pain medication to, because he's in withdrawal. And yeah, so treatment of opioid withdrawal will be done with, opioid agonist tapers. So you give some like methadone or like buprenorphine, okay, uh, or using symptomatic treatments like clonidine to reduce like the sympathetic symptoms, and for the diarrhea you give like loperamide or something. Okay. Long-term management of opioids is usually methadone, or like buprenorphine, so buprenorphine slash naloxone combination. Okay. uh, so what you need to know is naloxone is for acute overdose. Buprenorphine is for withdrawal and maintenance. Okay. Moving on to benzos and barbiturates. Okay. These are both CNS depressants that act on like GABA receptors. I don't know if you guys remember. What do you mean remember? You guys are taking it now. So they increase duration of the chloride channels, and one increases the duration channels open, the other one like keeps it, increases the frequency, okay, of the opening. So benzo intoxication presents like similarly to alcohol, so slurred speech, unsteady gait, they're going to be drowsy. One feature that is can distinguish them is the vital signs are normal. Okay, so pure benzos typically does not cause severe respiratory depression or hypotension unless it is combined with other drugs. Okay, in a pure benzo, it's not going to cause any of these. Okay, while barbiturates, on the other hand, is more dangerous. Like so, phenobarbital, whatever, can cause profound like hypotension, okay, and respiratory depression, and can lead to coma. So, if someone is, in a benzodiazepine overdose, you're going to give him flumazenil, sorry, which is basically a antagonist to the GABA A receptor. Uh, but flumazenil, one thing you need to know is it can cause seizures, especially in chronic benzo users. Uh, that's something to know. Uh, in practice, benzo OD is actually usually managed supportively, but for the purposes of your exam, you need to know flumazenil is like the reversal agent, okay? Because of the fact that flumazenil causes like as I mentioned, seizures. So in practice, it's a bit different, but for your exam purposes, know that flumazenil is what reverses it. For benzodiazepine withdrawal, it is important that you should know that withdrawal from benzos can cause seizures, just like alcohol withdrawal. And patients who are on long-time benzos, like, high doses, and they suddenly stop, can develop like tremors, anxiety, uh, you know, and seizures. Okay. Uh, but so essentially, benzo withdrawal, it looks like a milder alcohol withdrawal and can potentially like progress to like life-threatening seizures and delirium. Okay, so it is quite threatening, life-threatening. Okay. So for this, the treatment would be for the withdrawal itself is going to be gradual tapering of benzos, uh, and you're going to switch to like long-acting benzos and then like taper them off. Okay. Uh, with barbiturates, similarly, the withdrawal is going to be severe, and it includes like it does more of a cardiovascular withdrawal. So that also has to be tapered. Okay. Uh, the last one we'd talk about here would be like, inhalants, so like solvents like, glue and paint thinners or some like toluene. Uh, these are usually scenarios are like, teenagers, they come in with like a rash, something around their mouth or nose. It's like dermatitis around their nose, okay? Uh, and the intoxication of the inhalant itself is like, causes dizziness, euphoria, slurred speech, and can lead to like the person being very lethargic, okay? Uh, so it can also lead to death as well. So like something called sudden sniffing death because it can sensitize the myocardium uh, uh, and cause, arrhythmias. So it is dangerous. So on exam, you'll see like a teenage boy. He had like brief episodes of euphoria, rash around him, and like he's not doing well in school. And think of like chronic inhalant abuse. Okay. Uh, And it should just to know that the intoxication itself is very short-lived. It's like a very quick thing. It's not like a long overdose. It's like 15 minutes, maybe 30 minutes, okay? And the treatment is supportive. There is no antidote. Just ensure that, the person's getting oxygen and remove whatever is being exposed. And there's not much about inhalant withdrawal. Uh, maybe there's like a mild headache. Other than that, they don't really talk much about like withdrawal from inhalants. Okay, I hope that was clear. If there's anything, please let me know. We're gonna move on to the other thing. We already discussed this. We discussed this as well. We'll go on to glue sniffer Nash. Okay, so yeah, this is what the glue sniffer rash looks like basically. And now we're here at stimulants. Okay, so in regards to stimulants. As mentioned, these will increase the arousal of the nervous system. The big ones are amphetamines and, cocaine. So the first one we'll talk about would be amphetamine intoxication. Okay, so it basically causes euphoria, excuse me, hypervigilance, anxiety, irritability. Uh, look for tachycardia in a patient that, you're assuming that they have amphetamine or you're suspecting. So they should have like tachycardia, hypertension, and pupil dilation. Okay. And increased activity signs like, they'll be sweating and whatnot as well. Okay. So because amphetamines are releasing like, norepinephrine and dopamine, they can cause like cardiac arrhythmias, seizures, and like, hyperthermia in the overdose. So they are quite dangerous. Okay. So chronic methamphetamine use, anyone's seen Breaking Bad or any of the other shows that talk about like meth, you can see like they have severe dental problems. It's called having the meth mouth. Meth mouth. Yeah, pretty interesting to say. And skin picking. So they're like, they have like um it's because they have like a sensation, something called formication, where they sense like a bunch of bugs are crawling on them. So they're picking out their skin. So they're gonna have like a lot of sores on their body, okay? So in an exam question, it's gonna be like, oh, a very agitated person who's also paranoid, hasn't slept in days, is very thin, poor dentition, excoriations on their skin. All this is methamphetamine, okay, abuse. Um, Also they have paranoid delusions. This is something that can point towards it, okay? Uh, so they might have paranoid delusions and even some hallucinations. So you might sometimes think, oh, this person has like schizo. But actually, it's stimulant-induced psychosis. Okay. Uh, so if it's severe, management might include like benzos to sedate them or even antipsychotics for like, the psychosis if it's prominent. There's no actual antidote. We just treat it symptomatically. Uh, Withdrawal from amphetamines is, as I mentioned, withdrawal from any stimulants is going to lead to a crash where they feel like extremely fatigued, hungry, depressed, and they'll just sleep a lot. Okay. Uh, Even though in itself amphetamine withdrawal is not dangerous, the depression it can cause is like quite profound, or it can be quite profound, and can come with suicidal ideation. Okay. So just be aware of that in the questions. Okay. Uh, So I'll mention caffeine real quick, because it does come in the exam. So caffeine is like another stimulant. Caffeine intoxication, if you take like a lot of caffeine, can like cause restlessness, insomnia, diuresis, muscle twitching, and tachycardia and arrhythmia. That's basically what it can cause. Okay. Scenario is going to be like classic one, yeah, in which student drinks a lot of, coffee, presents with palpitations and anxiety, come to your thing, and you're like, oh, you're suspecting anything, any other bigger arrhythmia, and it turns out it's just caffeine. Okay. Uh, Withdrawal from caffeine usually just causes like headaches and fatigue, irritability, and just difficulty concentrating. That's basically it. Again, not dangerous, but pretty annoying. I'm assuming a bunch of you already, know how caffeine feels like and withdrawal from it. So we'll move on to the next one, which is more important. So cocaine. Cocaine intoxication is has some similarities to like amphetamines because both of them cause both increase the amount of amines, but cocaine is like short acting. Okay. So the key features will be they're going to be happy, so euphoria. They're going to have like psychomotor agitation. Their speech is like pressured, and sympathetically, they're like super activated. And what you should look for is like in dilated pupils, tachycardia, chest pain. Chest pain is also like something that you should know because it causes vasospasms, coronary vasospasms, and it can cause like that's why it can lead to NMI. Uh, They also often mention something called nasal septal perforation. Okay. Because, in chronic intranasal cocaine users, you'll see this, ischemic necrosis from like vasoconstriction in the nose. Okay. Uh, Cocaine intoxication also cause something called tactile hallucinations, which is basically bugs crawling on the skin. Okay. And similar to amphetamine use, uh, formication. Okay. Uh, but it's so I know it's risk factors are like for stimulant use. So they're young. I mean, so the young person usually not going to have an MI, okay, or ST elevation for no reason. So, that's already a sign. And, they're like in college or whatever. And, it points towards, so you want to see the risk factors for being a drug abuser. Okay. That's important as well. And treatment for cocaine intoxication is going to be with benzos. Is basically a lot of these is with benzos because you're trying to calm them down. Uh, okay. And beta blockers will be avoided. Okay. So avoid beta blockers in acute cocaine intoxicity because of the concern for like the unopposed alpha stimulation. So it can lead to worsening of hypertension. Uh, to control blood pressure, you can use phentolamine if it's needed. Cocaine withdrawal is similar to amphetamines, where it's like a crash and there's a massive depression post-cocaine crash and a lot of sleep. They're very hungry and they have vivid, dreams and whatnot. Uh, the patients feel very, very down. Like it is extremely depressing. Uh, and it's not life-threatening again, but it's something just uh, very uncomfortable, basically. Nicotine is basically the addictive component of tobacco. And nicotine is a stimulant that acts on nicotinic acetylcholine receptors in the brain, leading to increased alertness, improve attention, and causes the release of dopamine. Okay. That's why, nowadays there's like a big rush on like getting nicotinic patches and like, the gum and whatever. And they tell you it increases and helps you, blah, blah, blah. Do not believe them. Okay. So nicotine intoxication isn't usually described as an intoxication per se in exam. unless it's like a small child eats cigarettes, then you'd get like nausea, vomiting, maybe dizziness due to like acute nicotine poisoning. The high yield part is nicotine withdrawal. So smokers who quit can develop irritability, anxiety, restlessness, difficulty concentrating, increased appetite, weight gain. They have like it's insane amount of cravings for nicotine. And so the treatment would be nicotine dependency is like nicotine replacement therapy. So you have patches and gums, and you have medications like bupropion, uh, which is, an atypical antidepressant that also helps reduce the cravings. You also use varenicline, I don't know how to pronounce it, varenicline or Celine or however you pronounce it. Basically, it's a partial agonist at the nicotinic acetylcholine receptors, and it stimulates the receptors enough to give them like to reduce the craving and withdrawals, but it blocks the full effect of the nicotine. Okay. Uh, yeah. So on step one, varenicline or varenicline or however you pronounce this drug, is known as like the drug for smoking cessation. So watch for effects like, mood changes, whatever. Also bupropion as well is especially for people that have depression. Okay. So if a question is asking for the best medication to help a patient quit smoking, varenicline or bupropion, varenicline, I'm assuming that's how I pronounce it. Varenicline. I don't know. Most likely are the answer. So bupropion or the drug is most likely the answer. Uh, Now we'll move on to the next one, which is hallucinogens. So lysergic acid diethylamide, so LSD, that's what it's known as, uh, in the streets. Don't ask me how I know. A classic hallucinogen is actually I know it because it's just in this, LSD. It's just a short form, so no like crazy thoughts. Yeah, a classic hallucinogen. It's in all the movies and a lot of the songs or whatever there are. So it's very common. And it's like it causes vivid visual hallucinations and perceptual like distortion. Okay. For instance, like, you can hear colors or like seeing sounds and just very random things. Okay. Uh, People, that use it will describe like, okay, colors are extremely intense and objects will start to morph and in general, they'll also have like mydriasis, so dilated pupils. They'll have anxiety and paranoia as well, and flashbacks of like, hallucinogen, persisting perception disorder, something. That's what it's called. So it's like re-experiencing LSD, like, changes that you felt before, like these days or weeks after what it actually happened. Okay. Uh, so in an exam, it might just like, be someone going to like a music festival who like sees it, who went to a music festival and he's seeing like trails moving behind him or like objects, or something mean, his sensory experiences are like super intensified or something. Okay. LSD usually doesn't cause like dependence or withdrawal uh, and like fatalities from it are quite rare. Uh, and treatment is like supportive and you try to calm the patient down. And if he's like super anxious, you might give him benzos, but I don't really think they'll ask. Uh, excuse me. PCP, or phenylcyclidine, uh, is very high yield. Okay, so PCP is something that's a dissociative anesthetic basically, and it's an NMDA receptor antagonist. Uh, and causes a distinctive syndrome. Okay, so PCP is like very like it's very distinct. Okay, so PCP intoxication can lead to like psychosis. Okay, full-blown psychosis, like delusions, hallucinations, and like a violent behavior. Okay, like severely violent behavior. And they have something called nystagmus as well. So it's like classically rotatory or like horizontal nystagmus. Okay. And this person also is like he feels no pain. they're like, they have like analgesia and they have like a hypertensive crisis or hyperthermia as well in like severe cases. So people that like if you read into people that have done PCP, like the stories about it, it's insane. It's actually insane. I think some kid ate like a man's face in Florida and he was on PCP. So it's actually like it's a true story. Look it up. So PCP is and it's a for our case, it's a very good question when it comes because it's pretty straightforward to know because it's a very you're not going to get a lot of drugs that cause like severe violence and severe agitation and like nystagmus and all of this. Okay, so PCP should be straightforward to look on. Uh, uh, so a classic STEM patient is brought in by like police, and he's like extremely agitated. He has nystagmus, and he's like very hard to subdue, and he's like very strong, and he has psychotic thoughts. That's PCP. Okay. Uh, they could also like tell you like, oh, he's like breaking the handcuffs, and like he doesn't react to anything, like pepper spray or something. Like it's okay because this guy just doesn't feel anything. Intoxication can lead to like rhabdomyolysis and because of the fact of muscle rigidity or whatnot. So management is going to be benzos again because you want to sedate and to calm the patient, and you give him like rapid acting antipsychotics like haloperidol as well. Okay. There's no specific antidote. Uh, it's just about sedating the patient and making sure everyone else is safe. There isn't much known about like withdrawal. Uh, so yeah, that's basically for PCP. Cannabis or marijuana uh is widely used and like it's been tested out. So like marijuana like intoxication causes euphoria, a sense of like relaxation and like maybe lead to intent like but by that like sensory perception is like intensified. That's what it means by mild hallucinations. Also, you'll see this as very important physical sign will be conjunctival injection. So red eyes, basically. You're not going to find this in other things. And they'll be quite hungry, the word munchies that everyone's seen from like all the TV shows or whatever. And they have like a dry mouth and tachycardia. Okay. So cannabis withdrawal is generally mild. Uh, and symptoms are just irritability and anxiety, depressed mood, insomnia, and it's just like usually peaks in 48 hours and lasts about a week. So something else you need to know is like THC, so which is the tetrahydrocannabinol, is like the active ingredient. Okay, and it's very fat soluble, so it can be detected in urine for up to 30 days after heavy use. So a heavy user who quits a few weeks ago might still test positive on drug screen. Okay, so medically, marijuana is sometimes used to for nausea in chemotherapy patients as well, by the way, or like appetite stimulation in AIDS. But that's something I wanted to tell you. Uh, Also be aware of something called cannabis hyperemesis syndrome. Uh, in chronic users, which is like recurrent nausea, vomiting, and it's relieved by like hot showers. I don't know if they'll ask you that in step one, but it's just something to know, I guess. Um, MDMA, basically ecstasy or Molly, as it's known. Uh, Again, it's an amphetamine analog, which is, mild hallucinogenic properties. It does have that, right? So it basically increases serotonin and in the intoxication with MDMA causes like extreme euphoria and uh something called like uh sociability, which is like feeling like very intimate and empathetic towards people and all that. It causes an increase in like energy as well, and it causes something called bruxism, which is like clenching your teeth. So like just like intense like clenching of teeth. So vital signs in MDMA are going to be like, tachycardia, hypertension, again, the same thing, hyperthermia. And what can happen with this is what we mentioned previously, serotonin syndrome. So watch out for serotonin syndrome. because it increases serotonin a lot, and usually, people that are using it are like, they go to, clubs, or they go or whatever, and they're dancing all night, so they can overheat and dehydrate, and this can also lead to like hyponatremia. Okay, so uh, which is a big problem. So in an exam, it's going to be like, oh, a young person went to a rave party and he's like very friendly and energetic, but then, later on collapsed, and he has a high fever. So like he collapsed because of his hyponatremia, and most likely he has MDMA use. Okay. Uh, there isn't any like antidote. Uh, it's just basically, try to hydrate and keep him safe. Uh, for withdrawal, it's like similar to the other stimulants we mentioned, just like, feeling very down, and, just your mood is crashing, that type. Okay. Uh, any questions? Anything so far? Okay, I saw a question. I didn't know. Okay, Zainab asked this question. Wait, so taking it long term can cause seizures and sudden withdrawal? I'm sorry, I didn't notice there was a question before. So if you can tell me about what you're talking about, I will be able to answer you. Okay, that's good. Listen, is there another comment? Okay, you're welcome. All right. Now we're gonna go into pharmacology. So inshallah, this is gonna give you a good idea of, yeah, whatever the high yield topics are in pharmacology. Uh, so it is quite crucial. Step one often asks about like drug mechanisms or classic adverse effects, or gives you a patient scenario where you must like, choose the appropriate medication or whatever. So we'll break down the drug classes by antidepressants, antipsychotics, mood stabilizers, and something called anxiolytics, and some are like special cases. Okay. So this just talks about like different, this is pretty straightforward, I think. Behavioral therapies, cognitive behavioral therapy, all different types of therapies these are pretty straightforward. I think this is nothing that should be too tough for you guys. Uh, okay, so first thing we're gonna discuss would be antipsychotics. Okay. Uh, so in regards to antipsychotics, they're divided into typical, which is also known as first generation antipsychotics. Okay, so typical first generation antipsychotics and atypical are known as like the second generation antipsychotics. Okay. They primarily treat schizo, okay, and other psychotic disorders, but are sometimes also used in bipolar disorder for like acute mania. Okay. Also, you treat Tourette syndrome and sometimes OCD as well. Uh, so typical antipsychotics, the first generation, you have like haloperidol, fluphenazine, you have trifluperazine and chlorpromazine, just a bunch of other ones. Okay. And the mechanism is basically they block D2 receptors in the brain, and basically therefore they decrease dopamine levels, especially in the mesolimbic pathway. Okay. Uh, and this, I don't know if you guys were in the lecture yesterday, but mesolimbic pathway, because it's specifically in the mesolimbic pathway, typical antipsychotics are usually treating the positive symptoms of schizo. So hallucinations, delusions, and agitations. Okay, so it's usually treating these, and it is quite effective in treating these. Okay. The ones that have high potency, so you have the haloperidol, fluphenazine, are the ones that are going to cause more neurological side effects. And the low potency ones like chlorpromazine and thyroridazine are the ones that are going to have like more non-neurological side effects due to because uh, so they're off-target receptor binding, so they're gonna not bind onto the receptors that are in the brain specifically, so they're not causing neurological ones. They're going to cause other side effects without neurological ones. Okay, so we're going to talk about the side effects real quick. because these are the ones that are important and they always ask you. Uh, uh, so cholinergic neurons. So blocking dopamine causes like excess cholinergic activity, just like you have in Parkinson's. So you have like four syndromes, okay, that you need to know. And let me see if it was, I think it was in this slide. Yeah. Okay. I'm sorry for the slides being all over the place, but okay, yeah. Okay, so acute dystonia, we mentioned this one, okay? And these are like timing based, so you should also know like timing as well about them. So acute dystonia, muscle spasms of the neck, the face, the eyes, you have the torticollis, oculogyric crisis, okay? And usually onsets within hours to days of starting the drug, and it's treated with benztropine or diphenhydramine, okay? You have akathisia, which is it's restlessness and inability to like sit still and constant pacing. Uh, and it onsets is again usually like so the previous one, acute dystonia, we said was hours to days. This is days to weeks, and sometimes it might be thought of as like, oh, this person has anxiety or agitation, but it's no, it's actually a side effect of the drug they're taking. Uh, and treatment is with usually, benzos or beta blockers. Okay. They can also have tardive dyskinesia. Okay. So this is late onset. This is going to be like towards the end, like usually months to years. Someone's like taking this drug for like a very long time. And, it leads to like, because, they're using it for so long, it leads to upregulation of the dopamine receptors. So it manifests as like involuntary movements, especially of like the mouth and the tongue. So the person's like grimacing or like tongue protrusion or like lip smacking. Uh, Importantly, tardive dyskinesia can be irreversible or even worse if the drug is stopped. Okay. And treatment is quite difficult. So reducing or like switching to antipsychotics might help. You have newer treatments. You have like VMAT inhibitors, so valbenazine, like deuterbinazine. These are the ones that you should mention. But for you, you should not know what tardive dyskinesia is, right? So if you have involuntary movements that cause like, the lip smacking or whatever, and he's been on antipsychotics for a very long time, uh, this is basically tardive dyskinesia. And what are the treatments going to be? It's going to be like valbenazine for you guys, and deuterbinazine. Okay. We already discussed tardive dyskinesia, sorry, neuroleptic meningeal syndrome. There's something else. We got Parkinsonism. And so drug-induced Parkinsonism is, how whatever Parkinson is basically. So bradykinesia, rigidity, tremors, shuffling gait, masked faces, and all that. And usually in weeks. So you have acute dystonia from the name itself is al you have it. Akathisia is the one after it, which happens in a couple days. Parkinsonism is in weeks, and tardive dyskinesia if it's like you're doing it for a very long time. Uh, just to go over a neuroleptic malignant syndrome will be fever, so hyperactivity there, but they're rigid and they have, lead pipe rigidity, not clonus. They're going to have high creatinine kinase as well. Okay. Treated with dantrolene and bromocriptine. Okay. Uh, Another thing, you guys should know, in regards to, blocking of the D2 pathway. Let me see. Metabolics. Yeah, this would be antipsychotic. Sorry. Uh, okay. That it does have endocrine side effects. Okay, so blocking the D2 pathway in the tuberoinfundibular pathway can lead to prolactin increase because dopamine usually inhibits prolactin. I think that's an association you guys know. So it usually causes hyperprolactinemia. Okay, so galactorrhea, amenorrhea, and gynecomastia can also happen. Okay, this usually occurs in you know so first generation ones that are high potency ones. Okay, so haloperidol, but can also happen with risperidone. Okay, uh, so like patient is on antipsychotics and he starts lactating, or like a man develops like breast tissue. Think of like drug-induced hyperprolactinemia. Other effects are anticholinergic effects. You have more with like low potency ones, like you have dry mouth, constipation, blurred vision. Orthostatic hypotension is one of them as well. Okay. Uh, the one for that is chlorpromazine. That one is pretty that it causes orthostatic hypotension. So you might get a patient who's on like antipsychotics, whatever, and he gets up and he falls down, or it's very hard for him to get up. And ever since whenever he sleeps and once he wakes up after sleep and he gets up, he passes out. Okay, so what drug is this? Okay, chlorpromazine. Okay. Another thing about chlorpromazine, it also causes corneal deposits in the cornea. Uh, and the other one, thyroidazine, causes in the retina. Okay, deposits in retina, kind of resembles retinitis pigmentosa. If you guys have taken that, I'm assuming you guys have taken that. Okay. Weight gain and sedation are also another other things that are something that are known for the anticholinergic effects. Okay. Uh, So yeah, this in summary, the typical antipsychotics, they're like, D2 blockers. They're good for the positive symptoms, but they have a bunch of side effects. The ones we mentioned. And so a high yield concept is that in schizophrenia, treating negative symptoms, uh, like the Flack effect and social withdrawal, they often are not good with first generation antipsychotics. Okay, and this is why we have atypical ones or the second generation ones. Okay, and the first generation we mentioned the extrapyramidal symptoms, and they can have acute cholinergic ones as well. And yeah. So moving on to the atypical antipsychotics, you have like, risperidone, olanzapine, quidapine, clozapine. There's a bunch of other ones. You have the prezols as well, aripiprazole or whatever that name is. But yeah, they're basically they generally antagonize the 5-HT2 receptor, so the serotonin receptor, and D2 receptors. Uh, they have a higher ratio of serotonin to dopamine blockade. Okay. And they also sometimes block other ones. So you have the H1 and the alpha 1 as well. Uh, the net effect is that they treat both the positive and the negative symptoms of schizo, okay, to some extent. Okay. They also have the fewer extrapyramidal symptoms, as compared to the typical ones, uh, because the serotonin blockade, in the blockade of serotonin in the mesocortex area, increases the dopamine release, and this offsets the blockade of the dopamine in the nigrostriatal pathway. Okay. Uh, they still have side effects, specifically metabolic side effects. So, weight gain, increased appetite, they'll have like dyslipidemia, insulin resistance, and, risk of diabetes. And this is especially pronounced and seen with like clonazepine and olanzapine. Okay. So olanzapine is like notorious for weight gain. Okay. So USMLE question, patient on olanzapine gained a lot of weight and he has new onset hyperglycemia, stuff like that. Okay. So first generation, you're more looking at the extrapyramidal ones, okay? And second generation, you're looking at the metabolic ones, weight gain and whatnot. They have sedation as well, orthostatic hypertension, hypotension, all these things. These are more common with, so the anticholinergic ones are more common with second generation or atypical, okay? Same, you can have, again, elevated prolactin as well, because of the fact that, dopamine is being blocked. Uh, and each atypical drug has its own like specific side effects. For example, so something you need to know, something important. So I'm going to mention a couple important things about like specific drugs. So clozapine, for example, it's like the most effective treatment for treatment-resistant schizo. Okay, so if a person has like Has been treated with schizophrenia a couple times, okay? And now he's like, he's still not getting treated. Clozapine is a treatment-resistant drug, okay? And also the only one that shows reduced suicidality in schizo, okay? But the seizure side effect is it's like it causes agranulocytosis, okay? Uh, it causes agranulocytosis, and it's a let me see if there has. Okay, we'll probably stay here then. Yeah, it causes agranulocytosis. Okay, uh, which is why you'll have to monitor like WBCs or CBCs weekly. It also causes seizures as well. Okay, so remember, clonazepam agranulocytosis treats treatment-resistant schizo and agranulocytosis and seizures. Risperidone is like the most common like first line atypical, and it's known for like prolactin elevation. Uh, Other than that, yeah, that's what you need to know for risperidone. It's not that much. We need to know the name risperidone. You'll see it in exam questions. The stems, okay. Olanzapine. The main thing about olanzapine would be like high metabolic side effects. So weight gain, lipids, glucose, all of that. Uh, it it causes a lot of that effect. Okay, so you need to monitor your weight and blood gas with it. Okay. Uh, Quidipine. Uh, it's basically uh, quidipine is I guess used for sedation sometimes, and not that much risk of EPS, so extrapyramidal symptoms. Uh, what else? Let me think. Someone asked a question. Interesting. Does schizophrenia symptoms decrease in lactating women, say, since there's a decreased dopamine? Lactating women don't have decreased dopamine. Uh, I mean, yeah, I don't think that's the case in lactating women. And the pathophysiology behind schizo is not really like completely known as well. So it's not really the case in that. But yeah, but interesting question, I would assume. So yeah, as a rule, like first line for schizophrenia, so atypical antipsychotics are like first line for schizophrenia. Okay, so know that because they have less, extrapyramidal symptoms. Uh, acute psychosis or severe cases, you use like the typical one. So like haloperidol is going to give in like a quick tranquilization thing. Okay. Uh, maintenance usually they use atypical risperidone. And for a patient that's like unreliable, they usually use like long-acting injectable forms like haloperidol or like risperidone. Okay. But yeah, I think main things you got to know for the antipsychotics are know like the different ones, like which ones are causing the extrapyramidal ones and which ones what do atypical cause and what does the typical ones cause, and those the side effects are the main thing you got to know. Okay. Moving on to lithium. Okay, so this is a mood stabilizer. Okay, and they typically use mood stabilizer medications are typically used for bipolar disorder, and the key ones would be like lithium, valproic acid, carbamazepine, lamotrigine, all of these ones. Okay. Uh, the classic one mood stabilizer is lithium. The mechanism is not like fully understood, and uh, high yield, what you need to know for your exam would be like side effects. So lithium, no LMNOP, like, when spilling it out. Or the one that's over here, lithium, like lithium side effects is like lithium, uh, you know, it causes like polyuria and polydipsia and can lead to, hypernatremia and dehydration. I don't know if you guys took nephrogenic diabetes insipidus, but that's basically it, right? ADH uh, is antagonized. You'll have a lot of urine going out, polyuria, polydipsia, and, leading to hypernatremia and dehydration. Okay. Uh, Same thing, lithium can inhibit like thyroid hormone release, leading to, hypothyroidism. So weight gain, dry skin, bradycardia, all the things of thyroid, low thyroid. So TSH needs to be checked in people with on lithium. It causes Epstein anomaly, as mentioned. Epstein anomaly is, congenital heart defect where tricuspid valve is in the wrong position, it's malpositioned, okay? Leading to, right ventricle is not formed correctly. So lithium is avoided in women that are pregnant. Uh, Also, something important we mentioned previously is a narrow therapeutic index. So this means that there's a good chance or like a high chance of getting toxicity. We mentioned the toxicity, so ataxia, coarse tremors, confusion can always go into like seizures and coma, and any the risk factors are usually are like decreased lithium excretion. So, renal impairment or like they're on medication like thiazide or like NSAIDs or ACE inhibitors. All of these can cause, decrease in lithium excretion, high levels of lithium leading to lithium toxicity. Uh, yeah, lithium is still, even though all these issues are there, but lithium is still very the first line drug because of the fact that, it decreases suicide risk in bipolar patients. Uh, and it's still a very, it's still the gold standard for lithium, bipolar one. Okay. Uh, this is okay. I'm sorry because these slides are unorganized and this is giving me a bit of trouble. So we're going to bisoprolol and atypical antidepressants. Okay, so talking about antidepressants, if we're gonna go from okay, so you have different uh antidepressants, okay, and over here they're talking about buspirone. In regards to antidepressants, just okay. So I'll just tell you how I think about it. Okay, so you have SSRIs, you have SNRIs, you have the TCAs, MOIAs, and like some atypical ones. Okay. Guiding principle is that SSRIs are like the magic drug for like most conditions in psychiatry. Okay, first line for major depression, any anxiety disorder. Let me see where or I'll put it here and then we'll go back to whatever comes up. Okay. So for depression, anxiety disorders like generalized anxiety, panic disorder, OCD, PTSD, you have like bulimia. Uh, so yeah, if an exam question asks for like an appropriate treatment, newly diagnosed depressive patient or anxious patient, or like you don't know the question, SSRIs is mostly the correct answer. Okay. So kind of know the names of them a bit so that you know like fluoxetine or sertraline and citalopram. These are the ones that are usually mentioned. Paroxetine is also an escitalopram. So just know prams and a bunch of the flox ones are the ones that are important. Okay. Basically, they inhibit reuptake of serotonin, increasing levels of serotonin. Take about 4 to 6 weeks to act. Key side effects are, one of the notorious ones is like sexual dysfunction. Okay, and this is important because it comes up and they don't want to take the medication. So like they'll tell you, oh, I feel better, but now I have difficulty, functioning sexually. And this is like the most common reason for non-compliance. Other side effects would be like GI side effects, so upset GI, insomnia, uh, you know, and it can also lead to like SIDH. Uh, SSRIs can cause like hyponatremia in the elderly via like SIDH. Okay, it's rare, but it can happen. Uh, like in an overdose situation, SSRIs are generally safe. They don't really, cause an overdose. Okay. But if it's combined with like other serotonergic drugs, it can lead to like serotonin syndrome, as we discussed. So there's always something called a washout period when switching. So especially when you're going from like SSRIs to MAOIs, you need to wait for 2 weeks. Okay. Again, I'll repeat this again because it's important. And again, they ask questions about this. So you have to have a washout period when you're switching from one SSRI to another. So MAOIs, you usually have to wait some time because of the fact that there's some because of the fact of serotonin syndrome. Okay. Uh, you have something called SNRIs. Okay, they're the venlafaxine, duloxetine, and a bunch of other ones that I mentioned. Basically, they inhibit the reuptake of both 5-HT and NE and SNRIs are like for usually for depression and anxiety disorders as well. And so venlafaxine is usually used in treatment of uh, anxiety. Uh, so, for example, duloxetine, if you're looking at duloxetine are used for diabetic nephropathy. So, any question of like diabetic nephropathy, what is the treatment? Duloxetine, okay? And chronic pain conditions. Because of the fact that increasing norepinephrine will cause, helps with pain, modulating pain, okay? So, duloxetine is for that. Venlafaxine, usually you'll see it's treatment for GAD, so general anxiety disorder. Uh, Side effects are similar to SSRIs because of the fact, of serotonin. Plus, you have some sympathetic side effects from like the norepinephrine part. So blood pressure, heart rate, it might be the one that increases. Okay. So venlafaxine in particular, can cause dose-dependent blood pressure elevation. So, if you have a hypertensive, depressed patient, is on SNRI, watch out for that. Okay. So again, this is like something they'll mention in the exam. Oh, venlafaxine, and he's on like, or he's like hypertensive and he's depressed. Which medication can you not give? Or he's on these two, and which one should he take away, or something like that? Okay, and why? So, again, withdrawal from SSRIs and SNRIs are really serious, but they just have like a flu-like symptoms. Okay. Uh, TCAs. So these are like old antidepressants. They're not used that much now, okay, but they're still, it's interesting for them to ask questions about. So, a lot of the amitriptylines and nortriptylines and the other ones, what basically do they do is they block reuptake of serotonin in norepinephrine, just like SNRIs, but they also block a bunch of other receptors like histamine and alpha 1 and like acetylcholine receptors as well. Okay. So it's basically like SNRIs plus a bunch of other ones. Okay. Uh, this is why it's so good to ask questions about because of the side effects. Okay. So the key side effects are like the anticholinergic ones. So you have like, dry mouth, blurry vision, the urinary retention, constipation, tachycardia. Uh, so if in an exam, like, antidepressant is causing an elderly man to be confused and he has dilated pupils and urinary retention, most likely TCA. Okay. Uh, it also causes, antihistamine, so like they can lead to like sedation and weight gain. Uh, Also orthostatic hypotension because of the alpha 1 blockade, uh, and sexual side effects as well. Okay. Now the main thing for TCA is going to be the overdose of TCA, which we discussed already, but we'll go over it again real quick. So like TCA overdose is like extremely dangerous and common cause of overdose death. Okay. And the classic triad is like, the three C's, which are like cardiac toxicity, convulsions, and coma. Okay. And like, they'll tell you about it, oh, overdose, and they'll give you all the symptoms and signs, and like, so that's why you need to know. Okay. So cardiotoxicity is like because of the fact that it blocks the cardiac fast sodium channels. It's going to cause like a wide QRS complex, and can lead to like ventricular tachycardia or something. Okay. Uh, the patients also they can also lead to like hypotension because of the alpha blockade as mentioned, and comas and convulsions. So if they describe like on step one, someone is trying to kill themselves, like suicide attempt, and they took a bunch of antidepressant pills, and now he has like, wide QRS, tachycardia, and hypotension, and has a bunch of other effects of TCA. Okay, think this is like TCA. Okay. Uh, Treatment for TCA is like sodium bicarbonate. Okay. Which is, I was right, it was bicarbonate. I don't know why I said NaCHO3. So sodium bicarbonate, which is like given to, protect the heart and like narrow down the QRS. And what's it called? One other thing I wanted to mention is that although TCAs are not used as much, uh, in one of the TCAs, clomipramine, is effective for OCD. Uh, and another one is imipramine. It was used for bedwetting in enuresis. Uh, but because of its side effects, it's not used anymore. Okay. That's for like TCAs. And again, this is like all the beautiful side effects they give out. So for TCAs, I'd suggest this is the main thing you need to know. It's the side effects. Be very good with the side effects. SNRIs, I mentioned, be good with venlafaxine and duloxetine and what they cause. And SSRIs are also pretty straightforward. Now we're gonna go to monoamino oxidase inhibitors. Okay. Uh, Again, these are also old and not really used. But because they have interactions, they're tested. So yeah, phenelzine. I'm not gonna mention their names. Just all the other ones. Okay. Basically, they inhibit monoamino oxidase, and this is the enzyme that breaks down like monoamine, so serotonin, norepinephrine, dopamine. These are the ones that are broken down, and basically it increases uh, the level of these neurotransmitters. Okay, so that from itself, you should know like, okay, what are the side effects that are going to happen once I'm increasing these neurotransmitters? Okay, uh, so they're effective when they were used for like atypical depression and like phobias. But again, uh, they have severe side effects, so they're not used again. Okay. So, key point would be dietary restriction because the tyramine, so people that are on monoamino oxidase, they can't eat that much tyramine, so like aged cheese, cured meats, all that stuff. And that can lead to hypertensive crisis because of what you just mentioned, the fact that so many of these neuro transmitters are going to be released because of it. Okay. So the symptoms would be like severe headache, hypertension, risk of stroke or arrhythmia, and then treated again with phentolamine. Also, as I mentioned, MAOIs with serotonergic drugs, so SSRIs, SNRIs can lead to serotonin syndrome. So what you're gonna do? You're gonna do 2 weeks washout. Okay. So if someone's taking MOIs, you have to stop for 2 weeks. And then you can start any serotonin drug. Again, this is a very common concept that's tested in step one. Okay. So for example, another one is, for example, I was gonna say like someone on phenelazine, goes to like again party and comes back with like a throbbing headache or whatever. So this is like known as a cheese reaction. Uh, they also lead to orthostatic hypotension, and weight gain. Uh, what else is there? Yeah, I think that's basically it for MAOIs. It's not much left to talk about. But yeah, so in regards to atypical antidepressants, uh, this is like a miscellaneous group with a bunch of various mechanisms, and step one loves to test like their unique side effects and uses. So the ones you need to know would be like bupropion, mirtazapine, trazodone, and others like belzadone, all those ones. Uh, so we'll quickly go over some of them and talk about it, so you have a good idea. So bupropion is like an antidepressant that is used for smoking cessation, and the mechanism is like basically increase in norepinephrine and dopamine by inhibiting their like reuptake. Uh, Bupropion is notable because it lacks a sexual side effect. So because of its method of action is similar to SSRIs, but there is no sexual side effect, and it tends to increase libido. Uh, okay. Uh, or no, have no impact. Okay, so it's good for people that are on SSRIs, but they have like a sexual dysfunction. Okay. Uh, it can also be added onto SSRIs to counter the sexual effect. Uh, Also it can also cause like stimulant like effects like so like weight loss, insomnia. It can lead to increased energy, which is good for patients that are like in are depressed and they have like hypersomnia and weight gain. So that's why it's good. Uh, the high yield cautionary thing that you should know about bupropion is that it lowers the threshold of seizures. So at high doses or in susceptible individuals, like it can precipitate a seizure. So it's contraindicated in people with epilepsy or bulimia slash anorexia nervosa. Okay. Uh, you might ask why bulimia, anorexia? Because these people already have like electrolyte imbalances because of their eating disorder. So that already predisposes you to seizures. And yeah, that's why you do it. Okay. So they'll ask you a question about like, oh, this patient has like, they'll give you a scenario of bulimia and they're like, oh, which one is like contraindicated in them? Bupropion is the answer. Okay. But yeah, overall, bupropion, great choice for a young depressed patient who wants to quit smoking or is concerned about like sexual side effects of weight gain from or weight gain from SSRIs. Okay. Let me see. One question. Okay, I'm sorry if I'm not looking at the questions. Okay, it just says thank you. Uh, so mirtazapine is another one, and it's an atypical antidepressant, and it's quite unique. Okay, why did it go here? Sorry. Okay, mirtazapine is yeah is an atypical it is so mirtazapine's action is basically it's an alpha 2 adrenergic receptor antagonist. Okay, alpha 2 adrenergic receptor antagonist, which basically means it disinhibits release of like norepinephrine and 5-HT. Uh, and also it's a 5-HT2 and 5-HT3 receptor antagonist and a blocker of like H1. Okay. So basically, what you need to know is like it's causing increased serotonin, okay, and norepinephrine transmission and some histamine blockade, okay. So mirtazapine, the side effects are usually what makes it like significant for like certain patients. So like it leads to sedation due to like H1 blockade and can increase appetite and lead to weight gain. So, mirtazapine is often used in a person who's depressed and he can't sleep and he has like poor appetite or weight loss. So, elderly patient lost a lot of weight, trouble sleeping might benefit, from mirtazapine to, help them sleep and increase appetite. Uh, As like a typical scenario of a question, by the way. These things are like literally, if you know this, they'll like, ask these questions exactly. Additionally, also, it has like a minimal sexual side effect. Uh, yeah. Uh, Alternatively, they can also ask you like, oh, if someone's already has weight gain, so then you don't give this to them as well, okay? Because that would cause an increase in weight gain. Trazodone, a common mnemonic for trazodone, which I still remember, is trazodone is known as trazobone. Uh, the extra, it's like it's spelled out as like, and explain this why. I'll explain. I guess I should have told the mnemonic at the end. So basically, trazodone is a 5-HT2A again receptor antagonist and uh HT reuptake inhibitor and kind of also blocks like H1 and A1. So it's mainly known for like sedative properties, okay? And it's like mostly used in treatment of insomnia associated with depression. Uh, and high yield side effect is like priapism. And This is why it's known by like the classic mnemonic like trazodone. Trazodone is equal to trazobone, where like there's like TRA triple Z O B O N E because the triple Z means like it causes you to sleep, and bone is for like penile erection. Okay. So if a question mentions like antidepressant cause a patient to go to the ER for like an erection, that's trazodone. Uh, Other side effects would be like orthostatic hypertension, hypotension, and like dizziness and sedation. And it's usually given not as like an antidepressant, but like more of like to help people to help like the insomniacs sleep at night. Uh, And yeah, there's some other ones they're not mentioned here. I'll quickly mention them. I th there were let me see if they were at the beginning. Uh, let's see. Sorry. So quickly, a couple of them are I guess I was gonna mention Vilzodone and uh, Vilzodone and Vortoxine, but I guess I'll no need to mention those. I think that's basically it. Let me see if I have some things in my notes that I want to mention that I haven't mentioned. Not really. I mean, I think there's a couple things I wanted to talk about specifically. Uh, that would be like mood stabilizers, okay, which we didn't really go over. So I'll go over them quickly, even though they're not mentioned here. Uh, we mentioned lithium. You have a couple other ones that are mood stabilizers as well that you should know. Okay, so valproic acid, it's actually an anticonvulsant, okay, but it's like first line stabilizer, first line for like mood stabilizing in bipolar disorder, especially someone that's like bipolar with mania. Okay. Uh, and it is quite effective. Valproate is like almost as effective for mania as lithium, and it's often like preferred in patients with mixed features or like rapid cycling. The side effects that again you should know for like valproic acid is hepatotoxicity, and it's teratogenic and can lead to like neural tube defects. And specifically, the neural tube defect that they always ask about will be spina bifida. Okay, so again, these are things you should know. Uh, the big ones, these are like, so the big ones on exam would be hepatotoxicity, neural tube defects in the stomach, sorry, in the fetus. It's an active. Uh, Another one that's, I mean, it's used for trigeminal neuralgia as well. So that's, uh, I'm hoping that you already learned that in neuro. In bipolar, it's used for like acute mania and like prevention. Okay. The side effects for that would be like aplastic anemia and agranulocytosis. Those are the ones that you need to look out for, like SIADH as well, along with neurotube defects. And again, I'm mentioning these because these drugs, when they talk about them, they're usually, going towards side effects, or they'll tell you this side effect happened in the exam. And then what is the drug or like what is the mechanism action? So like carbamazepine, for example, mechanism action is like sodium channel blocker. Okay. Valproic acid is like GABA. Okay. It increases GABA and, blocks sodium channels. So that's what you'll have to pick out. Like they'll be like, oh, we gave this bipolar guy like this medication and he had hepatotoxicity. What is the method of action of the drug that was given? That's the question for like step one, basically. Same goes for like, carbamazepine. They'll ask you something and they'll tell you, okay, he had SIDH, or they'll give you this. They won't tell you he has SIDH, but they'll tell you he's like, hyponatremic. Uh, and then you'll have to figure out, okay, what drug can you give to a person that is, bipolar that's going to cause hyponatremia? So carbamazepine, okay. Uh, The last one is lamotrigine, which is also an anticonvulsant, but its main use is bipolar depression. Okay, so this is also important for you to know. And the mechanism is again sodium channels and glutamate release. It blocks that. Side effects that is significant again that you're supposed to know is Steven-Johnson syndrome. Uh, and that's I guess that's the main thing. I guess I'll leave you on that for the treatments. So for like basically in summary, like mood stabilizers, you have lithium, which is watch out for thyroid, kidney levels, and in pregnancy, valproate, you have, LFTs, teratogen, which is specifically spina bifida, carbamazepine, watch out the CBC report, okay? Because carbamazepine leads to like aplastic anemia and agranulocytosis. And you got to watch out, it's teratogenic as well. And lamotrigine is Stevens-Johnson syndrome, okay? Uh, The other things, I guess, let me just double check if there's anything that I haven't mentioned. Uh, thing. Yeah, so bupropion, we talked about bupropion already. Buspirone, again, so this is basically comes under anxiolytics. Okay, so for anxiety disorders, SSRIs and SSNRIs are like first line for chronic management, but we also have anxiolytics. We already discussed benzos, so I don't think there's a need to. Buspirone is the one we didn't mention. Uh, buspirone. So it's a unique one because this is a non benzodiazepine anxiolytic, okay? And it's used for generalized anxiety disorder. Mechanism is basically serotonin. It's partial serotonin agonist, okay? It causes no sedation and it has no risk of addiction and it has no interaction with alcohol. So it's all unlike benzos, okay? And it won't make you sleepy if you drink it. So what a lot of people do, or what you need to know is that, when people are on benzos or these people that use drugs, they'll take benzos together with alcohol, okay? Because that makes them, I guess, feel better or whatever, right? So bisoprolol, or buspirone, I'm sorry, pronunciations are bad at this point. Uh, has no risk of sedation and it has no risk of addiction and no interaction with alcohol, okay? Uh, Bad thing is it has a slow onset, so it takes 1 to 2 weeks to achieve the effect. So it's not really useful for acute anxiety, but it's good for chronic management of general anxiety. Uh, what's it called? Yeah. So they might tell you like, a patient history of substance abuse has general anxiety disorder. What is the best to prescribe? You'll take buspirone because it has no abuse potential and the side effects are like minimal. And it does not cause sexual dysfunction like SSRIs do. Okay. Uh, I think that's basically it for the so let me see real quick. No questions. Okay. Uh, Here we'll go over real quickly. Quickly highlight some special cases or exceptions where particular drug is favored. So, for example, for OCD, SSRIs are like first line, but like clomipirine, which is like a TCA, is particularly affected and effective. For PTSD, you have SSRIs like sertraline or like paroxetine are first line. Uh, and like parazosin is help used for like nightmares in PTSD. Uh, for anxiety disorders, specifically the social anxiety disorder, uh, you need to know that SSRIs and SNRIs are used for chronic, but beta blockers can be used for the performance only beta blockers are used. Okay. Panic disorders, if it's acute, you give them benzo. If it's long term, you give them SSRIs. Uh, Again, for specific phobias, the best thing would be like behavior therapy, which is like, exposure therapy is the first line. Okay. Uh, I guess we're gonna go over eating disorders. We haven't gone over them. But bulimia is usually treated with like fluoxetine, which is SSRIs. Uh, Although like anorexia has no proven medication for the treatment, uh, olanzapine is sometimes used, okay, in anorexia, okay, to treat them because of the fact we talked about how olanzapine is really, really causes like weight gain, okay. For insomnia, first line's like, sleep hygiene and CBT and whatnot, but medications would be for insomnia are like the ones with Z. We didn't mention them, but basically know that for insomnia, there's medications that start with Z, called zolpidem and like some Z drugs, just like Zalpilon or some other basically drugs with Z. Okay. Uh, there are also other ones you can use. You have melatonin, or Ramilton, which is another option. Okay. Or what we mentioned was low dose trazodone. For ADHD, first line is stimulants like methylphenidate or like amphetamines, which improve the focusing. That's basically what we use. Another thing I want to mention would be like electroconvulsive therapy. Uh, it's not really pharmacological treatment, but for severe depression, ECT is used, and there are questions that were asked. Okay, so like person with severe depression, he's not eating, nothing's worked on him, and yeah, ECT is the answer for that sort of scenarios. Okay, uh, so quick roundabout on like side effects and what to remember. So like olanzapine, like agranulocytosis is a big thing. Risperidone, I mentioned prolactin is increased. Chlorpromazine would be like, corneal deposition. You'll have thyroidazine is like retinal deposition. Haloperidol was the extrapyramidal side effects, and neuromalignant syndrome can also happen. Lithium, you had like hypothyroid and Epstein anomaly and like diabetes insipidus. Valproate, you had like hepatotoxicity and neural tube defects. Carbamazepine is also another one that causes agranulocytosis. SIDH and what else? Lamotrigine. Lamotrigine causes the Steven Johnson syndrome. SSRIs in general, biggest side effect would be sexual dysfunction and can lead to serotonin syndrome. The SNRIs we're fearful for would be hypertension, okay, specifically venlafaxine. Uh, TCAs, we said the, cardiac toxicity, comas, the three C's basically, and MAOIs would be the tyramine crisis. Uh, I hope that helped out with the pharmacology. Okay, I know it's a lot of things put together, so that might be a bit confusing, but yeah, we'll go. And I think the whatever's remaining is quite quick after this. Okay, it's personality disorders. So basically, it's like personality disorders like characterized by like inflexible, maladaptive personality traits that can lead to like, distress. Uh, and they usually begin in like early adulthood and are divided into like ABC, wheeled, and they're like often labeled as weird, wild, and worried. So cluster A uh is going to be the weird ones. Okay, so they're like odd or eccentric. Okay, and so you have paranoid, schizoid, and schizotypal. Okay, so paranoid personality disorder would be like pervasive distrust and suspiciousness of others. Okay, so these individuals are, everyone's motives are like malevolent, right? Everyone's like a bad person to them. Okay. They're, often they accuse a lot, and they, you know, they bear grudges and they're reluctant to, confide in others and whatnot. So any question, think of someone who's like unjustifiably like, suspects their like spouse of like cheating or like coworkers on like conspiring against them, so yeah, so again, the reason we're talking about these is like a lot of people might think, oh, this is like schizo or like delusional disorder or whatever, but no, these are like, paranoid disorder, okay? So we have to differentiate between them. Common method mechanism is of remember we talked about different mechanisms of ego defense. So projection is one of them, and they're common in people that are paranoid. Okay, they project a lot. Uh, Schizoid personality disorder. Think of schizoid, like someone who is like a loner who doesn't really talk to, he does not really go into social relationships, and he prefers to be alone. And you know, Basically, yeah. So detachment from social relationships, and he's like, he is restricted emotionally. And they don't even want like it's like they typically do not desire close relationships. Okay, and they're indifferent to like, criticism or praise or whatever, as they talk about being aloof, basically. Uh, the last one is schizotypal personality disorder, and this is like the most eccentric one in the cluster A. Think of like schizotypal, like, he's like magical type, they have like odd beliefs or like magical thinking and, unusual perceptions, telepathy and bizarre fantasies, and like they dress strangely or whatever. Uh, so like importantly, like schizotypal is often like, described as the pre-morbid personality of a of schizophrenia, and some portion of these patients might actually develop schizophrenia, but uh in actual schizotypal, personality disorder, they do not have any sort of psychosis. Okay, it's just magical thinking. Okay, so like for example, man, he has like odd speech. He dresses in like a peculiar way, and he believes he can read like, people's auras or something. Okay, and he's like socially awkward. So the phrase like ideas of reference is often used in like question stems, like they might think of like ordinary events have like special meaning towards them, but not, they're not fully diluted, but yeah. They're basically like very awkward and like odd people. Okay. Uh, so in summary, yeah, paranoid, they're like suspicious and bear grudges. Schizoid is just like I don't want to talk to anyone, and they're socially detached. Schizotypal is, just magical and just awkward thinking. Okay. Uh, Also need to know is that they're ego syntonic, which means it goes with their ego. They don't think this is a problem. They don't think this any of this is weird. Okay, cluster A people. Again, these are like personality disorders. There's no like actual treatment or anything for these people. Okay. Now moving on to cluster B, these are the wild ones. Uh, for the mnemonic, it's like bad, borderline, and flamboyant, and best. Okay. So the first one is antisocial personality disorder. So antisocial is like basically disregard for and like violations of everyone else's rights. Okay. That's basically it. Uh, these individuals are usually, breaking the law, they lie, they, get into fights, they're assaulting people, and they have no guilt. Okay. And they're impulsive, they're irresponsible. Uh, you have to be 18 and above to get diagnosed with this. Okay. And I remember we talked about conduct disorder yesterday. So conduct disorder before the age of 15. Okay. And once it goes over 18, you're going into antisocial personality disorder. Okay. Uh, Also, they use something known as rationalization to, as an ego defense mechanism. Uh, yeah. The next one is borderline personality disorder. It's high yield because this also comes up. So we mentioned borderline personality disorder. They'll use the ego defense of splitting, where, everyone's either good, so at one moment they'll love someone and next they hate them type, splitting. Okay. So it's characterized, borderline personality disorder is characterized by like having unstable mood, unstable self-image, unstable, self relationships, and they have like really intense interpersonal relationships, that go from like basically idealization to like devaluation. Okay. So they'll love the person at one moment, and the next thing you know, it's like they hate them to like the core. Uh, okay. Can someone have multiple of these together? Uh, I mean, they could, but again, I don't really know, to be honest, if they can or not have them together. Uh, but why not? I mean, yeah, I don't know. I don't know the answer to that question. They can have them multiple of them together. I'm sorry. Yeah. So yeah, the next one, so borderline personality disorder, unstable, and you'll see Usual scenario is like, they come up, often a patient, commonly a young woman, she's in an unstable relationship. She has a lot of self-harm episodes. There's a lot of mood swings and uh like, she'll talk about like making suicidal gestures, just because, her boyfriend told her he might leave from her, right? And they have like the splitting thing in which, they'll love the doctor one day and the next day they'll hate them, right? And they have like intense fear of abandonment, okay? And they often display like impulsivity as well. So they'll do like substance abuse or like, binge eating or whatever, and recurrent suicidal ideation. Like there's a lot of like threatening to do suicide or like talking about it, or there's self-mutilation, so like cutting and whatnot. Okay. So there's they ask a lot about this. This is quite common. And the other thing you need to know is the treatment. Treatment for this is dialectical behavioral therapy. Okay. So yeah, this is quite high yield and it comes often. Okay. The next one is histrionic. So basically from the word itself is like they're attention seeking and they're like excessively emotional. Okay. Histrionic individuals are like, dramatic and flamboyant and are like very sexually provocative. So they crave spotlight. So they may dress like seductively and act inappropriately. Be very flirtatious. And they have like very rapidly shifting, shallow emotions. And they like to draw attention with like with their physical appearance and like maybe exaggerated stories or whatever. Uh, and they often have the impression like the relationship is like just much more intimate than it's really is. So for example, a woman, she meets the doctor briefly or whatever and then refers to him as like her best friend, and like and she starts behaving in like a theatrical manner. She might be like histrionic, and she's like overly flirtatious with the physician, and she's really concerned about her appearance and like very dramatic emotionally, right? Um, yeah, that's basically it. For the treatment for that is like psychotherapy, for to help them out. The next one is like narcissistic personality disorder. The key features are basically grandiose, like feeling like, oh, I'm the best, okay, and the need for like admiration and just lacking empathy in general. So narcissistic individuals have like an inflated sense of like self-importance, and they believe they're like special or like superior or whatever. And like, they have like fantasies of like, unlimited success and power, brilliance, beauty, whatever, Uh, and they require, excessive, admiration and praise, and like, again, sense of like entitlement, Uh, they can also be very exploitative, like, they can like because they lack empathy for others, so they can just take advantage of others. Okay. Uh, Interestingly, their self-esteem is actually very fragile. They're like very sensitive to criticism or defeat, so they often react with like rage or disdain when someone like, challenges them, or they become depressed or whatever. Okay. So they're although they say it's, very inflated, but in reality it's quite fragile. Okay. Uh, so, for example, it might be, described like a physician who belittles his colleagues, the exam question, right? He makes fun of his colleagues, but like himself, he can't handle any feedback and always needs to be like seen as the best. And like, that's a narcissistic personality disorder. Or another one is like CEO who demands like, special accommodations and like, has no regards for his employees or whatever. Uh, you know, uh, yeah. Uh, that's basically it for narcissism. So differentiating, I want to say, uh, in summary, basically for cluster B, know that like antisocial ones, they basically break the law and they don't care. Borderline is, unstable relationships, they cut themselves up, so self-harm, and they have like mood swings and splitting. Histrionic is, they're attention seeking and they're dramatic and they're very sexually uh, provocative. Okay. Narcissistic, elevated self-esteem, thinking they're like very high actually, but in general they get very defensive and like they can't react to criticism. There's a phrase called narcissistic injury. Basically that means it's like, how poorly your narcissist reacts to like criticism. Okay. So moving on to the last one, which would be basically here they're talking about like extreme emotion and center of attention or whatever. Yeah, so cluster C personality disorder, which would be the uh it's known as the worried, anxious, or like fearful. So that avoids like includes like avoidant, obsessive compulsive personality and dependent personality disorders. So avoidant is are they're socially inhibited, they feel inadequate and are like hypersensitive to like negative evaluation. Okay. They really want relationships, but they fear rejection and criticism so much that they avoid social interaction. They're quite timid, shy, and they're hurt by like any slight comment. And and an avoidant person, they're gonna turn down promotions and they're gonna avoid like new activities because of fear. Okay. They often like perceive themselves as like very inept and inferior, and they won't engage with others unless they're like they're sure they're being liked. Okay. Unlike schizoid personality, the avoidant person does want to have friends, but is too afraid of rejection to seek them out, right? Schizoid doesn't really want anyone. He's aloof. He doesn't care. Okay. Uh, so on the exam, it's going to be like, a man who has no friends, declines social events, but in therapy, he admits like he wishes he has friends. Okay. And he's just terrified of being ridiculed. Okay. Uh, the next one is obsessive compulsive personality disorder, and this should not be confused with obsessive compulsive disorder, which is like an anxiety disorder with true obsessions and compulsions that are like ego dystonic. Remember the word dystonic, where they know this is a problem. Here, it's ego syntonic. Okay, OCPD is ego syntonic. The person does not see this as a problem. They're preoccupied with, being orderly, perfectionism, and control. Again, you might meet, someone in your batch that's obsessive compulsive. You know, they're very inflexible with rules and moral codes, and they're like excessively devoted to their work. Uh, you know, so for example, a person who's like, has a very rigid schedule becomes upset if, any detail is out of place, and has trouble completing tasks because, they're trying to, perfect everything. Uh, yeah. So that's basically it. You'll see like, an exam question is just going to be someone that's like a perfectionist, like maybe a medical student or something. Okay. Last one is like dependent personality disorder. These individuals have like an excessive need to be taken care of. They're like seriously submissive and clingy, and they have great difficulty making like normal life decisions. They often cannot like assume responsibility. They always are afraid of being left to care for themselves, and will often stay in like, abusive or like unhealthy relationships because of the fear of abandonment. Essentially, they lack like self-confidence or like, they need constant support basically. Okay. Uh, yeah, that's basically it. Okay. And I think for personality disorders, what you need to know, important for the exams, I'll tell you is like borderline is very important. Okay, borderline, histrionic, these ones are very important as they come a lot in the exam. Uh, and these ones you should know. The others are also important, but I'd suggest borderline is the most important one out of all these. And schizoid and schizotype will know the difference between these as well. What differentiates them. Antisocial is important because of conduct disorder and the specific, the age. So be careful with those as well. Just make sure you know the difference between OCD, OCPD, schizotypal and schizophrenia, and schizoid and avoidant. Make sure you know the difference between those as well. And yeah, that's basically it. Okay. So moving on to somatoform disorders. So somatic symptom and related disorders, known as somatoform disorders. So these are conditions where, let me see if there's a question. No. Okay. So conditions where patients, experience physical symptoms that are not actually fully there. Like, so they're not conditions that are explained by medical conditions. Okay. And it's a psychological factor that's playing a role. It's crucial to differentiate various types. Okay. Uh, and yeah, we're gonna go over a couple. Interestingly, I met someone who had like a somatic disorder, and the person was perfectly fine, but he could not. He had like problems walking, and he like I stayed with this person for a while. They're like a relative, and it was very weird to see because this person's completely normal and nothing is wrong with them, and they've been to the hospital multiple times, but they're just, like they were, he had a problem where he was just stiff. His whole body was rigid, and he was telling me he had like pains all over, but there was nothing wrong with him at all. But you could tell he was in obvious distress, right? It wasn't something like he was making it up, but he was in obvious distress. So yeah, it is pretty interesting. Indeed, Zainab, it is definitely whoa. So yeah, so first one, we'll discuss. Okay, so the sorry. So yeah, somatic symptom. So the first one we'll talk about would be the somatic symptom disorder. Okay. So the patient actually has like one or more like physical symptoms that causes distress and significant disruption in daily life. So this is the person I'm talking about had this basically, and he has like excessive thoughts or feelings or or behaviors related to these symptoms. So such as like persistent anxiety about health or symptoms, or like excessive time or energy is devoted towards them. Like the symptoms to this person are real. Okay. Even if medically there nothing is there, they are real. And they're really overly worried about that. Okay. And they have a lot of visits to the hospital, and they'll go all sorts of tests, and they're not like reassured by any negative test. And as I'm explaining this to you, I'm thinking about the person, and he literally had exactly all these. Okay. Uh so for this person, the focus is people like this, the focus is on symptoms. Okay. And the symptoms can be of any type, and they can change over time. Uh, Usually it lasts more than 6 months. Okay. Uh, Management of this is often by having like a primary, so you should have one primary care provider. So this shouldn't change a lot, and you should like have regular appointments with them. And essentially, it's like a therapeutic, type thing where you're, trying to tell them the patient feels heard, but generally avoids, unnecessary interventions. And the key is to not tell them it's all in your head, because that doesn't work. Okay. You acknowledge that it's actually a thing, that they feel it, and you slowly address them to you get better. Okay. The next one is illness anxiety disorder. And this is something that's known as like hypochondriasis, probably seen in like TV shows or whatever, where the patient does not actually have any physical symptoms, but is extremely anxious about having, some symptoms. Okay. So normal stuff like, mild aches or whatever, they'll think of like, oh, they have cancer or something. Okay. And they excessively check their body for like signs of illness. Uh, unlike somatic symptom disorder, there's no actual like, symptoms. And it's just mainly fear. They just have like fear. So for them, again, regular scheduled visits, maybe do some CBT, but just try to help them manage it. Okay. Uh, the next is conversion disorder, or it's called functional neurological symptom disorder. So this involves like neurological symptoms sensory motory that are incompatible with known neurological diseases. So an example is like sudden blindness or paralysis. Uh, sudden blindness or paralysis, non-epileptic seizures or like mutism. They can't swallow or something, and the patient is not like actually, they're not like consciously faking it. They're truly actually experiencing these symptoms, but there's no organic cause. Okay. Uh, uh, And a classic feature in these patients is called, like, it's a French word which I'm gonna butcher it, but it's like label indifferent or indifferençant or whatever, however you pronounce it in French. Basically, they have a lack of concern about the nature or, like, or the implication of their symptoms. Okay, so for instance, like a young woman suddenly becomes unable to move her arm after like a traumatic argument, but she appears like it's completely normal to her. She's not concerned about the fact she cannot move her arm at all. Uh, it's not like everyone's gonna have this, but it's like a buzzword. So if they tell you like LABA indifference, or like basically you see a patient that cannot move their arm or whatever, like, it's just, and they don't care about it. This is like, keyword type thing. Uh, And again, it's like, a scenario of like neurological symptoms that do not match any exam findings or the anatomy at all. And what you need to know is that they're not intentionally making it up. It's just the symptoms are an unconscious expression of like their psychological, well-being right now. They're not doing well psychologically. This is what's going on. And these are pretty interesting to actually see in real life because it doesn't make sense at all. But, yeah, the mind has extreme power to do a lot of things. So yeah. uh the next one we're going to talk about are going to be like the conscious, like, feigning disorders in which they're consciously doing the stuff. So factitious disorder, which is basically known as like Munchausen syndrome. Okay, this was, I think, an episode in Dr. House as well. uh Basically, consciously, the patient is faking or induces like physical or psychological symptoms, but there's no external incentive except to assume the fact that they're sick, and that is to get medical attention and sympathy. Okay. So the motivation is like internally, like psychologically, they need to be taken care of rather than like, tangible where like it's monetary or whatever. Okay. And they go to like great lengths. So they'll inject themselves with like bacteria to cause infection or like contaminate their urine samples or like, blah, blah, blah. And they can be like dramatic and eager to undergo tests in the extreme form, which is like Munchausen's. They like travel between hospitals and do like a whole thing. And it's again, it's pretty interesting to like hear stories. Okay. Uh, so factitious disorder imposed on another, or Munchausen by proxy, is basically when, so the first one is basically imposed on self, and the other one is imposed by proxy. So often like a mother, produces like illness on their child to gain attention. Okay. So this is like considered abuse. Okay. Since the victim is being harmed, obviously. Uh, if you see like a patient, like in an exam question, who like overly eager for procedures and the labs are inconsistent, it kind of, points towards fictitious behavior. Another one would be like long history of hospital visits in different cities with like vague symptoms and vague tests being done everywhere. That's also like Munchausen's. Uh, and again, you have to realize there's no external reward for this. They just want attention. So there's no external like, oh, monetary reward or anything. Okay. So monetary reward is like malingering, okay, which is consciously like faking or like exaggerating symptoms for external gain. And these external gains could be like, avoiding work or obtaining financial compensation, military service or whatever. So like for example, some prisoner says he's like, I hear voices, so he can avoid like a jail sentence or something. Malingering is not like a mental illness. It's more like fraud, like, oh, I'm too sick to come to the lecture today or something. That could also be considered malingering. Okay. So, patient claiming, they're disabled, so they can take, they have back pain, but, they're seen in exercising in the gym. They just want to get the disability check or something. Uh, yeah. So no fictitious, there's no obvious external reward. Malingering, there's actual reward. Uh, yeah, that's basically it for those ones. Okay. This is uh just talking about how I have no idea. I really don't know what this is about, so we'll just go on. Uh okay, so we're moving on to eating disorders, and this will be the last thing. We'll try to keep it quick as well. So eating disorders, uh you can see the first one we'll talk about is actually we start with anorexia and then we'll go to bulimia. Okay. So anorexia, the key features are they have intense fear of gaining weight and they have like a distorted body image and they impose self-starvation. Okay. And they have really low body weight. Okay. So anorexia is diagnosed when body weight is like 85% less of like expected for age or less than 18.5 BMI. Okay. And patients who have anorexia, they refuse to like maintain normal weight. They have often like, their perception is distorted. They always see themselves as like fat or like emaciated. Even though they're like emaciated, they'll see themselves as fat. And you have like two subtypes. You have like restricting, which is weight loss, which is achieved through like, just not eating at all. Or you have the binge eating slash purging type where they eat, but they just, they purge, so they keep vomiting. Okay. Uh, the biggest thing, so if a patient is, underweight and still binging slash purging, it's anorexia, binge and purge. If the person is uh in normal weight and they're binging, so which is like vomiting or whatever, that's like bulimia. Okay, we'll get to bulimia, but just to tell you the differentiation between like if you're underweight and you're vomiting, that means you're in uh underweight by BMI type. If you're vomiting, that's still anorexia, okay? But if you're normal weight and you're vomiting, that's bulimia. So that's the big difference. Differentiator is the BMI, okay? Typically, anorexia affects adolescent girls, especially in like high achieving families because, they have comorbid depression or OCD-like traits. Um, because of the fact they're starving themselves, they have a lot of, usually they have amenorrhea. Okay. Because of the fact, menstrual periods, will be lost because of decreased GnRH. And then, you have low LH and FSH. And basically, reproductive function is shut down because of the fact there's low weight. So amenorrhea, osteoporosis because low estrogen. You have Lenogo hairs, which is on the body because of malnutrition. You have cold intolerance, and it can lead to bradycardia and hypotension if it's quite severe. A bunch of others, they can have electrolyte abnormalities and like, anemia and whatnot. And if they vomit, if it's the vomiting type, again, they'll have like parotid gland hypertrophy and, dental erosions, as we showed in the beginning. Okay. Uh, the one of the most serious complications is cardiac arrhythmias. Okay. And this is often due to the electrolyte imbalances that we mentioned. So, especially, because they're purging, hypokalemia is a big thing. And the most common cause of death in anorexia is due to cardiac arrest, okay? Due to low potassium. And anorexia has actually a high mortality rate in amongst like psychiatric disorders, up to 5 to 10% per decade, okay? So this is quite a high in regards to all the psych disorders. Another one is you have something called, they can have seizures as well, again, because of the electrolyte imbalances. Another one is refeeding syndrome. Okay. So refeeding syndrome is, because of the fact uh, the uptake of potassium and magnesium. So when someone like, they're severely malnourished and they're refed too quickly, what happens is that insulin secretion spikes because you just fed them. So that will do what? They'll drive phosphate into the cells. Okay. It'll drive the phosphate into the cells and you're already like, hypo everything. So it's going to be hypophosphatemia. This leads to like, cardiac arrhythmias, muscle weakness, blah, 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 rhabdomyolysis. And again, because potassium and magnesium will also go into the cells. So it causes even more of a problem. Okay. So when you're treating anorexia, you treat them slowly, not with, you don't refeed them quickly. Okay. And monitor their electrolytes. Treatment of anorexia is, nutritional rehabilitation, psychotherapy. In severe cases, you hospitalize them. There's no like highly effective medication, but olanzapine, as we mentioned previously, is an atypical antipsychotic that is used because it causes weight gain. Okay. Uh, and yeah, just know that, definitely, definitely, very important to know that, 18.5 and less, and differentiate. You can be there's a binge eating type and there's just a fasting type. So binge eating slash purging. If you're binge eating slash purging, if you're underweight, that's anorexia. If you're overweight, if you're normal weight, then that's bulimia. So bulimia is basically recurrent episodes of binge eating, followed by compensatory behaviors that are like inappropriate, like purging, or where they excessive fast. It could be non-purging. So there's purging and non-purging. It could be they're vomiting a lot, they're fasting a lot, whichever one. And these behaviors at least occur for like weekly for 3 months. Okay. Uh, but critically, you need to know that the fact that bulimic patients maintain a normal body weight, or they can be slightly overweight. Okay. They don't typically become underweight. And they're very occupied usually with their body shape and weight. But unlike anorexics, they have normal weight because their intake often bounces out with some of the retention calories. Okay. The lab findings and some of the physical findings in bulimia. Uh, uh, So you want to see you'll see like parotid gland enlargement. So they'll have something called chipmunk cheeks because from chronic vomiting. They might have serum amylase might also be elevated because of the salivary glands activity is quite high. The dental enamel erosion, the Russell sign over here on the knuckles, and the electrolyte imbalances, again, chronic vomiting is going to lead to the hypokalemic, hypocaloremic, metabolic alkalosis, because of the loss of HCl. And they have volume depletion as well. So you have, uh, you'll have what's it called? So because you have volume depletion because you're vomiting, your RAS is going to activate, so your renin-angiotensin system, and this leads to like increased aldosterone, which will lead to further potassium being lost and sodium being lost. Okay, and this is why again they have metabolic alkalosis, and yeah. So, in regards to bulimic patients, they're usually, ashamed of what they're doing, so they usually hide it. Uh, Unlike anorexia, they actually, seek help, or at least acknowledge that something's wrong. Uh, the high yield concept you need to know is BMI is normal, and this is the distinguishing factor, because very low in anorexia and typically normal or a bit high in bulimia. Okay. Uh, so for bulimia, the first line treatment is psychotherapy, specifically CBT, tailored towards the eating disorders. After that, SSRIs and particularly fluoxetine. Uh, Fluoxetine is the answer for medications in the exam. Uh, the other thing I want to mention is avoid bupropion in bulimia, as mentioned earlier, because of the fact that there's a risk for uh, you know causing a seizure. Okay. And I think that's basically it for another one I wanted to mention was you know there's a bunch, but pica. So pica, real quick, is basically it's another eating disorder that they persistently eat non-nutritive, non-food substances for like more than a month. They eat dirt, chalk, clay, paint chips or whatever, and this is usually associated with like iron deficiencies or other deficiencies like zinc. Can happen in like in developmental disorders or in pregnancy. Uh, what else would be there? There's something called a binge eating disorder that's not mentioned here, but I'll just mention it real quick. It's basically characterized by like recurrent binge eating episodes without like compensatory behavior. Okay, so they eat a lot, so they eat excessive amounts in like a small period, and they feel they don't have any control over it, but they do not purge or otherwise like compensate. Okay. As a result, these people become like overweight and obese, and like this is recognized by DSM-5 as now like a relatively new diagnosis. Okay. Treatments for this would be like, psychotherapy, SSRIs, and there's a medication that's also approved. It's called I don't even know how to pronounce it, but it's lisdexamfetamine. That's basically the medication for it. Okay, long name, but there's also approved for it. So binge eating without any purging, usually overweight, obese. They don't purge and they don't feel control when they're going through binge eating episode. Okay. And yeah, that's basically it for the eating disorders. I think we only have sleep disorders left. Uh, let's see. I think it's prayer time. So I'll go pray and we can then just finish off the sleep disorders. Okay?
All right. Thank you so much, doctor.
You're welcome. Yeah, we're just okay. Uh so yeah, we're just gonna, finally go over a couple of sleep disorders and try to focus on the high yield ones, okay? So you have sleep terror and sleep nightmare, enuresis, narcolepsy, and cataplexy. Okay. So the one that's not here, again, I'm sorry it's not there, but I'll just mention it real quick and then uh we can talk about it. Is is insomnia, okay? Insomnia is basically difficulty initiating or maintaining sleep or waking up too early, which basically, leads to daytime impairment. Okay. So many medical and, psychiatric conditions can cause insomnia. So, pain, anxiety, whatever. So in the exam, you might see conditions on how to basically, questions on how to manage insomnia. So primary insomnia means it's basically not because of some other condition. First line treatment is going to be like sleep hygiene and CBT for like insomnia. So sleep hygiene means like, regular schedule, avoid drinking coffee, uh, you know, uh, no screens or phones before going to sleep or something like that, right? For short-term acute insomnia, use like hypotonic medications, so you'll use like, non-benzodiazepine hypertonics, like the ones I mentioned a couple of zolpidem. Zolpidem is the main one, like, and there's like two other ones like the zalpolone or something. So basically Z medications, okay, which act on the benzodiazepine receptor, and cause sleep, okay, but they have less risk of dependence. Melatonin, everyone knows melatonin, so that's one, and Remel okay? That's also another option. Uh, the the other one after this we're going to talk about will be, real quick, I'll go over narcolepsy. Okay. So narcolepsy is, excessive daytime sleeping in which you have like sudden attacks, of, sleep attacks basically, and you have an abnormal REM sleep regulation. Okay. So there's like two types of narcolepsy. You have type one, which is like, with cataplexy, and cataplexy is basically, losing all of your muscle tone following like strong emotional stimulus. So that sometimes people like, they laugh and they'll just fall down, okay, because they can't control their muscles. And type two is like without cataplexy. In steps, you just need the one that's cataplexy, okay? Uh, Basically pathophysiologically, for narcolepsy, there's like type one, there's like loss of hypothalamic neurons that produce like something called hypocretin or orexin, okay, and that's the thing that keeps, like, it's a neuropeptide that maintains wakefulness, okay. So clinical features to know about narcolepsy are, daytime, you're excessively sleepy, okay, uh and then you're gonna have narcolepsy. Okay. And you also have sleep paralysis, which is like, you wake up and the patient feels like, as a patient, they feel like they're falling asleep, and they experience like the inability to like move for like a few seconds while they're fully conscious, right? It's very frightening. I've had a couple friends who told me they're like, they had sleep paralysis. So yeah. And there's something called hypno gogic, or like I don't know how to pronounce this, hypnopompic and hypnagogic or gogic. So basically this means uh hypnopompic is like hallucinations upon waking, and hypnagogic is like hallucinations as one is falling asleep. Okay.
These are like vivid and often like really frightful hallucinations. Okay, and they might see like a stranger in their bedroom or something like that. Okay, and people that have narcolepsy, they go into REM sleep very quickly. Whereas like normal individuals, they take like 90 minutes to go into REM sleep. But like people that have narcolepsy, they'll take like minutes to go into sleep. Uh, Something else you might need to know for step one is like, CSF. They'll check CSF and they'll have like high levels as of hypocretin 1. So sorry, CSF hypocretin 1 levels are low in narcolepsy, okay, type 1. And but like this is something it's like it might get mentioned in the question some like, oh, low hypocretin levels in CSF, okay? So treatments for like narcolepsy is like modafinil, which is like for daytime, first line for daytime sleepiness, and stimulants like amphetamines can also be used. And for cataplexy, and you use like venlafaxine or other SNRIs or SSRIs, okay? And another medication that's like quite specific is sodium oxybate, which is, taken at night. Okay, this is for narcolepsy with cataplexy. Okay. Yeah, that's basically it for narcolepsy. Uh, we'll talk about parasomnias, which is basically like, unusual behaviors or like experiences during sleep. So the two most tested are like sleep terrors and nightmares. They're called parasomnias. Okay. Uh, so So night terrors, or sleep terrors, as they're known, whichever one, are up in children during their deep non-REM sleep, so like stage three. Okay, stage three and three. So stage and three sleep, okay? And it's usually in the first third of the night. So within a few hours of falling asleep, okay? And the child like often will, sit up and start screaming and maybe, is like sweating and has tachycardia and cannot be consoled, okay? Importantly, they're not fully awake, and they do not often respond to comfort. And in a few minutes, the child calms down, goes back to sleep, and in the morning, they'll have no memory of the episode. Okay. This is like what differentiates it from like nightmares. Okay. So sleep terrors, they wake up, they scream, they're going to go back to sleep, have no memory in the morning, no memory in the morning. They also don't wake up when you talk to them. Uh, while night terrors, night terrors are, as I mentioned, they're non-REM sleep. Okay. Uh, and they're common in kids, and they usually outgrow it. And yeah, how do you manage it is like, mainly reassurance for the parents that it's usually benign, it's nothing severe. uh it's in very severe cases I might give them benzos, but like not really, right? uh and how do you differentiate it from nightmares? Nightmares is basically scary dreams that occur during REM sleep. The previous one was non-REM. This is REM sleep. You have scary dreams, and this usually happens in the second half of the night. Okay, is when REM is long. Uh, the person typically awakes from the nightmare, and they usually are fully alert and they can recall the details. Okay, uh, and they're usually frightened, but they can be consoled, and they usually have trouble going back to sleep. They're common in children, but can also happen in adults. People that have experienced like PTSD or under stress, they can go through this. Nightmare disorder is when it's like recurrent nightmares that causes like actual distress. Uh, and yeah, management for this is if they have PTSD related insomnia or like nightmares, parazosin is given to reduce nightmares. Okay. Other than that, for childhood ones, it's just reassure them and not much in that. Okay. So night terrors, know that non-REM N3 sleep, N3 stage. First of the night, they have no recall. They wake up, they scream, they go back to sleep. They'll be normal. Uh, Nightmares, it's in REM. Late night, scary dreams they can recall, and it's in REM sleep. Okay. Um, The next one we'll talk about will be something known as bedwetting and uresis. Uh, this isn't technically a sleep disorder, but we'll talk about it. Uh, so enuresis is basically, involuntary voiding of urine at night in a child that's like 5 years or older. Since bedwetting is normal up to a certain stage of development. So by age 5, most kids like achieve night dryness, but if it persists, it's primary nocturnal enuresis. So first you got to rule out, how do you, check out nocturnal enuresis? So basically you're gonna uh, rule out any causes like a UTI or like diabetes if if indicated, especially if after it started after a period of dryness. And most cases are developmental delay or most cases are like caused by developmental delay of bladder control. That's like the main reason behind it. Management is like motivational therapy and behavioral strategies. So bedwetting alarm, also known as enuresis, is like a device that senses the moisture and wakes up the child. And, as we talked about conditioning yesterday, this conditions it. You limit fluids, make a voiding schedule, and so on and so forth. A medication known as desmopressin, which is an ADH analog, can used, can be used. Basically decreases the urine production at night and is like effective in short term. Another medication that was used but isn't because of its side effects was imipramine. It's a TCA, causes a lot of side effects. Uh, and yeah, that's basically it. Okay, for enuresis. Uh, it's so last thing I'll mention before I think we'll end will be okay. Last thing I'll mention will be there's something called REM sleep behavior disorder. I don't know if it's that's important, but when uh, it's when older adults they start acting out their dreams and they punch and kick and whatnot, and it occurs in REM sleep, but with normal muscle atonia, so they can move. And this is kind of involved in like Parkinson's and Lewy body dementia. So REM sleep behavior disorder is seen in patients that have Parkinson's or Lewy body dementia. Okay, and yeah, that's basically it for I guess, sleep disorders. And that's also like the end of our presentation. Thank you guys so much. If you guys have any questions, feel free to ask. Let me see if there was any questions added. No, no questions were added here.
Thank
Yeah,
you.
thank you so much. I hope that was helpful.
That was
And
really helpful, and I'm so sorry for the delay that we started at. There was
no,
some
it's okay.
issues.
No, it's
Thank you
perfectly fine.
so much for the psychiatry lessons. They were genuinely very interesting. It was actually so
You're
much
welcome.
fun.
Well, I'm very happy you enjoyed them. Thank you so much. And best of luck on your exam. Have a blessed Ramadan and Assalamu alaikum, everyone.
Thank you. Welcome, Sam.